Okay, Dr. Narula, I'll give a very short introduction in Portuguese. Then I will ask, at the end of this introduction, I will ask Romeu to invite you to come to your lecture, okay? It will be 100% English. The discussion will be in English. Just the introduction will be Portuguese, okay?
I mean, after being with you and Romeo for such a long time, if I don't understand Portuguese, then shame on me.
Great, great. Muito bom. É um prazer muito grande começar esse programa educacional promovido pela Conexa. A Conexa começou sua jornada como uma operação de telemedicina. Mas dentro do seu propósito de jornada, e o que interessava era a jornada, ela se transformou numa integração de soluções para entregar valor à saúde. Esse é o propósito da Conexa. Ela não é uma plataforma, ela é uma integração de soluções, e quantas soluções houver ou vierem, elas serão integradas com um foco. O foco é transformar a saúde. O foco é atingir o paciente. E o foco é ajudar a gestão a ser mais eficiente. Por isso, o conceito de valor que trazemos no nosso DNA. A melhor maneira, o primeiro pilar da entrega de valor é a educação. E por isso, a Conexa tem esse programa educacional para compartilhar conhecimento. Dentro dos tópicos educacionais, não há tema mais relevante para a nossa sociedade global do que discussão de Covid. E a atualização da Covid em seus mais diferentes tópicos. Para isso, nós focamos aqui nessa reunião em Covid e coração. E quando nós falamos em educação e conteúdos de coração, fomos buscar 2 usuários da Conexa, parceiros da Conexa, que são stakeholders para a promoção do nosso propósito. A Sociedade Brasileira de Cardiologia, aqui representada pelo professor amigo, nosso amigo, professor Evandro Tinoco Mesquita, um orgulho da cardiologia, que preside o Departamento de Ciência Cardíaca e coordena, senhores, a Universidade do Coração da Sociedade Brasileira de Cardiologia. Não poderia estar melhor representado. O professor Marcelo Queiroga, presidente da sociedade, estará conosco. Nesse momento, ele está tratando um paciente com infarto agudo. Ele está fazendo uma angioplastia nesse momento e vai se juntar a nós. Junto da SBC, para representar o capítulo de educação entre os nossos parceiros, nós trazemos aqui um dos maiores grupos educacionais do país, o Grupo Ânima, e através de uma de suas verticais digitais, a Inspirali. A Inspirali é uma plataforma digital de educação à distância, mas também presencial, e por ser a distância presencial, híbrida. Como um dos maiores grupos educacionais, a Conexa se sente contemplada com esses 2 pilares, educação, coração, cardiologia. E no fim, para falar de coração e Covid, como disse o professor Evandro, eu vou aproveitar suas palavras. Nós trazemos aqui uma lenda. Nós trazemos uma lenda que foi considerado um dos maiores 5 inovadores da cardiologia americana, sobre quem o Circulation escreveu um editorial sobre a vida desse inovador. Esse inovador já publicou mais de 800 papers de alto impacto. Vejam, senhores, 800 papers. Ao longo da vida, que acompanha o professor Narula, ele não fala senão daquilo que publica, senão daquilo que pesquisa. E por isso ele é autor de 30 livros, entre eles a consagrada Bíblia da Cardiologia Mundial, o Hearst. O Dr. Jagat Narula é editor da última edição do Hearst. Então, essa lenda é uma erudição da cardiologia mundial. Ele é o editor do Journal of American College of Cardiology, Image, e é professor de medicina, de cardiologia e de radiologia da Universidade do Hospital Mount Sinai de Nova York. Teve passagem pelo Massachusetts General Hospital de Harvard, e é um currículo, mas acima do currículo, e o currículo outras pessoas podem desenvolver. O Dr. Narula é a maior alma que conhecemos da cardiologia mundial. Por isso, eu trago o presidente do nosso conselho, o presidente do nosso conselho médico, o nosso querido Dr. Romeu Domingues. Eu peço ao Dr. Romeu Domingues para introduzir o seu amigo Jagat Narula para a nossa audiência. Por favor, Romeu.
Obrigado. Boa noite a todos. Obrigado pelos amigos que estão nos assistindo. Botelho por ter convidado o Narula. Foi uma excelente sugestão. Nosso amigo, uma referência na cardiologia mundial. Muito obrigado. Agradecer ao Evandro também, querido amigo, professor, que a gente tem muita admiração. E, para não falar mais, eu vou, passar para inglês. Professor Narula, Jagat, thank you very much. We are very proud to have you here with us. It's a great pleasure. You are a great friend. You love Brazil. You love our people, our colleagues. And I know that we're going to have a great presentation because you are one of the best cardiologists that you have met and a special person. A lot of people in Brazil love you. So thank you. It's really a great pleasure to have you here with us talking about this topic that will be very important, cardiology and COVID. So again, thank you very much. And the pod is yours.
Thank you, Romeo. So honor is entirely mine to be able to be with friends like Dr. Dominguez, Dr. Botelho, and Dr. Tinoco. It is truly a privilege to be able to present, and I will try to do my best here. We'll keep it very slow, and will try and interact as much as I can. And Dr. Botelho, please stop me wherever you feel that I need to repeat things or am I not coming across clearly. Although I will try and do my best. So I'm trying to share my screen here. And can you see the screen?
Yes, we can see now.
And here perfect. I can go on. How is that?
Wonderful picture you selected.
Brilliant. Okay, because it was evening. First, I was thinking of obviously bringing the daytime picture, but then I thought that since I'm giving the talk in the evening, I should have an evening picture of beautiful Rio. And my fascination for Christ the Redeemer, and the day that we will visit the place together with Romeo and you, Roberto G. So, COVID-19 and heart. It is almost 1 year now that the COVID was first reported from Wuhan, China. And this report, which is the first report to appear from Wuhan related to Wuhan pneumonia, that came out in February of last year in JAMA. You remember that the people who had COVID pneumonia, these are the folks who are older. And if they were older, it was more likely that they were admitted to the intensive care unit as compared to those who had the non-intensive care, suggesting thereby that old age was one of the most important risk factors for a severe disease. Also, severe disease occurred in the people who had cardiovascular disease, as you can see here, or if they had risk factors for cardiovascular disease, including hypertension, diabetes, cerebrovascular disease, and also obesity, which we found on later after this report was first presented. Not only that, if you look at the Center for Disease Control of China, they demonstrated clearly, confirming the earlier JAMA report, that as the disease increased, and you can see on the x-axis that the decades of the age as it is increasing, and by the time the patients are octogenarians, you will see that the death is significantly higher. It is about 4 times higher when the patient is 80 years old as compared to the current mortality. And current means the mortality as was seen in March of 2020. Also on the right hand panel, you will see that this was the mortality rate in March last year in China. And when the people had the evidence of pre-existing cardiovascular disease, diabetes, chronic respiratory diseases, hypertension, you will see that the likelihood of mortality was much higher as compared to the average mortality rate attributed to COVID-19. How exactly does the COVID-19 affect the body? Let us start with a little bit of a pathologic basis of how the COVID-19 or the so-called coronavirus enters in the body. And this is the coronavirus 2 or the novel coronavirus 2 as we called it, the nCoV-2. As we all know that the coronavirus basically on its surface does have certain proteins. The spike protein, which is very common between the regular coronavirus and as you had seen earlier in the MERS also, that this disease or the Middle Eastern coronavirus, that the spike proteins were there. So it is something similar, but not the same. And as you can see here, that this is the spike protein or S protein as shown here in the green color. And then there are some other proteins, and the other important proteins being the nucleocaspid protein or so-called N proteins. So these are some of the common proteins which you can see onto the cell surface of the coronavirus. Now, how does this coronavirus enter into our body cells? And as you can see here, that these are the ACE2 receptors. And we all know that ACE2 receptor is one of the most ubiquitously available, and it is present on almost all the cells of the body, quite like the ACE1 cells or the angiotensin converting enzyme 1 cells. So this is the angiotensin converting enzyme 2, which is the counterbalancing receptor to the ACE1. And as you know, that ACE1 is a detrimental molecule, the ACE2 is a counterbalancing molecule, or it is an important molecule which is a favorable molecule, and it does everything against the ACE1 receptor, suggesting thereby that this is vasodilatory, this is natriuretic, this is antioxidant, it is anti-inflammatory, it is anti-remodeling, suggesting thereby that all good properties against what you see in the ACE1 receptors or as you see in the angiotensin 1 receptors. So these spike proteins, they bind to the ACE2 receptor after these have been changed configurationally. And how does this configurational change occur? It is by the presence of some co-stimulatory molecules, as you can see here, which I'm showing here in the orange color, yellow-orange color here. These are some molecules quite like what they are called as TMPRSS2 molecules, that when the TMPRSS2 molecules engage in this combination, they make the change in the spike protein, quite like this here, that some of the domains of this spike protein, they stand up, and then they are able to bind to the ACE2 in a way that this moves into the cell by the process of endocytosis. So what is very important here is that you have to have a coronavirus which has to be alive, and when it is alive, it has the spike proteins on top of it, and that it has to have an ACE2 receptor, as well as it needs to have the co-stimulatory molecules, as you can see here. And this combination allows this virus to literally crawl on the cell surface, get into the endocytotic vesicle, and then it gets into the cell. It is the vesicular transportation in the form of endocytosis. So, certain organs which have significantly high expression of the ACE2 molecules, they will be able to take up the coronavirus, quite like here you will see that it is in the tracheal epithelium. It is also in the nasal epithelium. It is also on the tongue. It is also on the gastrointestinal system. It is also on the urinary system. That as the coronavirus comes in, and here you would see the electron microscopy pictures, you can clearly see the coronavirus sitting here in the insect. You can see the corona of the virus, or those which are made up of the spike proteins. And here it binds to the ACE2 receptors, and then it is internalized. And as you can see here, that now it has started to come into the alveolar epithelium. So here you will see that these are pneumocytes in the alveolar epithelium, and they bind to the pneumocytes, and they get into the pneumocytes type 1 and type 2, predominantly type 2, the ones which are able to produce the hyaline on the alveolar epithelium. So here you can clearly see the presence of the coronavirus or novel coronavirus in this electron micrograph in this particular case. Now, once it has come here, it starts its damage. And as you can see here, that this is the earlier picture of the pneumonia that is settling in. So when the pneumonia starts to occur, there is the alveolar damage here. You can clearly see the diffuse alveolar damage in this particular case. Clearly see this acute hyaline membrane formation here, which obviously tells you that the integrity of the epithelium of the of the alveoli is losing, and that through the interstitium it is also affecting the endothelium, because around the alveoli are the alveolar vessels, and now this leak starts to occur from the vessels here. Now in the diffuse alveolar damage, now we are seeing the organizing phase here. So the organization has started to occur, and then you will find the reactive pneumocytes. Here the healing has started to occur. You can clearly see various giant cells here. These large cells that you can see, these are the giant cells. And you will also see that there is the perivascular lymphocytic infiltrates. So it is a full-blown inflammation at this time of the healing when it has started. And if we let this process continue, the lungs really turn into leather. Once this process starts to get into the late stages, it completely destroys the lung. It is absolutely a very abnormal sight when you really look at the delayed process in the lungs when we look at them during the autopsy in these cases. Here you will see that there is a staining for the spike protein, suggesting thereby that the virus is here. And again, here you will see that these are the pneumocytes, and with the macrophages, some macrophages here, and also the spike protein in this particular region. Now, at this point in time, as I earlier said, that once the epithelium starts to get damaged, the virus would start getting into the interstitium. From there, into the endothelium of the capillaries. So you have the alveolus here, you've got the interstitium, you've got the capillary around the alveoli, and you will see that all the cytokines and all the damage is occurring. The monocytes which are here, these are turning into the macrophages. They are going through the interstitium, into the endothelium, into the vasculature around it. So here are the pneumocytes type 2. You can see it here. The coronavirus is coming into this virus. And as you can see here, that the TTF1 staining, that means the endothelium is lost, almost completely lost here. The epithelium of the alveoli is completely lost. And there are the interstitial capillaries are also showing the loss of endothelium here, suggesting clearly that the damage has started to occur and the coronavirus is now getting into the bloodstream. Now here you will see that it has reached the enterocytes or into the intestines, and there also you can clearly see the coronavirus here, and similarly here in the proximal convoluted tubule epithelium of the kidneys also, that it reaches wherever you have got the ACE2 receptors. And as I told you, that in the enterocytes as well as in the kidneys, the ACE2 is very extensively present or expressed, quite like the lungs and the nasal epithelium, etc. Now, once you have it in the blood vessels, you see how it starts to modulate the endothelium. Now, endothelium, we all know, is an organ which has anticoagulant properties, anti-aggregatory properties, that nothing can come and stick to the endothelium. Endothelium produces multiple type of chemical substances and chemokines and other things, which basically do not let anything happen to the endothelium, and endothelium remains glistening clean because it produces heparin, it produces thrombomodulins, it produces prostacyclin, it also produces fibrinolytic molecules, quite like the plasminogen activators, whether it is the urinary plasminogen activator or the tissue plasminogen activator. It is anti-inflammatory. It produces a barrier that nothing can cross the endothelium. Then it is a vasodilator because the nitric oxide is formed here. It is antioxidant, that it takes care of all the oxidative stress. So the healthy endothelium is an extremely important organ. It is the largest organ of the body, and it basically protects us from having any damage to the organs that it is supplying the blood to. But once the virus is in here, once the macrophages which have collected the virus, they come in here, they start to produce the cytokines and they start to produce the damage. Now, the damage that occurs in the endothelium occurs in 4 stages. The endothelial damage type 1, or we call it a type 1 activation, that in the presence of the cytokines, the type 1 activation suggests that the stored granules of the proteins are released. There is nothing new which is forming, but whatever proteins were stored in the endothelium, they are released. And the 2 most important proteins are von Willebrand factor, which is, as you very well know, is a procoagulant molecule, and P-selectin, which is expressed. So P-selectin comes here, and that is expressed onto the cell surface. Now, these P-selectin molecules, when come on the cell surface, the von Willebrand factor comes and sticks to it. P-selectin will bring in platelets. Von Willebrand factor will start the coagulation. So there is a sinister cycle, or there is a damaging cycle that starts, and the thrombus starts to produce. And as you know, that the thrombosis in the vessel, or so-called intravascular thrombosis, is one of the most important unfavorable happening in the COVID-19. That is something which is related to the adverse or unfavorable outcomes in the COVID-19. Now, the stage 2 of the activation by the cytokines, by the macrophages, by virus getting into the endothelium, because endothelium also has the ACE2 receptors. And some of the viruses get in there. The entry of the viruses is not great in the endothelium. Otherwise, all of us would have died with the COVID-19 infection. Why? Because the co-stimulatory molecule, as I told you, the TEMPRESS, it does not express as much on the endothelium, and that is the reason that we are still able to fight with the disease. Now, in the phase 2 activation, or type 2 endothelial cell activation, the E-selectin is produced, ICAM is produced, VCAM, these are the adhesion molecules which bring in various cells like the monocyte, the neutrophils, and all other molecules which come in there. And when the neutrophils specifically come in there, these neutrophils are able to produce something what we call as netosis, or the neutrophil exit traps, that these are created, that they put their DNA out. The neutrophils put their DNA out and they trap the virus. They don't let the virus escape from there. And then there is also the thrombosis which starts to occur. In the phase 3 of the endothelial activation, there is something what we call as anoikis. And anoikis is when the endothelium loses its home. It's a Greek word. And when it loses its home, that when the endothelium starts to slough off from the basement membrane, or there is a denudation of the basement membrane, and all these proteins, they start to violently produce as the endothelial cell undergoes apoptosis. And finally, the endothelium undergoes necrosis, and all the proteins which are linked, most importantly, the thrombomodulin and von Willebrand factor, which are associated with the necrosis of the endothelium. And this is something what you call as AMP or DAMP. The PAMP or DAMP, which is the pathogen-associated molecular patterns or damage-associated molecular patterns, that there is a significant amount of pro-coagulant and pro-thrombotic activity starts. So an endothelium, which was a very favorable organ, and as you can see, now it turns into the unfavorable organ, because now it starts to cause coagulation. Now it starts to prevent fibrinolysis. It causes inflammation. It removes the barrier because it has been lost. The endothelium has been lost. It becomes a vasoconstrictor, and it becomes pro-oxidant. And these are neutrophil exit traps that are formed here. So here you would see that significant amount of thrombosis that starts to occur in the vasculature, small vasculature as well as large vasculature, minor and major, micro and macro vasculature, both in the venous side as well as in the arterial side. So you can clearly see the pulmonary embolism here. Here there is a deep venous thrombosis. Here it is the prostatic vein thrombosis that is occurring. In this CT scan, which Romeo will like to see, that the splenic artery here is totally occluded by the thrombus. You can see that in this. And when the patient died, the autopsy was performed, and you can see that the thrombosis of the splenic artery is occurring here. And you can see that it has got significant amount of inflammation in there. And here it is in the higher magnification. And here we can show that there is a complement deposition. And whenever there is a complement deposition in the vessel, it means that there is a significant amount of hypersensitivity reaction going on. When the complement deposits in the myocyte, it tells us that it is the ischemic damage. But when it deposits in the vessel, it tells us that this is a hypersensitivity phenomenon. Now here you will see that there is a lot of fibrinoid degeneration which is occurring in this case. Now, again, Romeo would like it because this is the new advances here which the radiologists are making. And they are now using the GP1 molecule here, which is the platelet binding the substance. It is a small little molecule which has been labeled here with fluorine. The data comes from Korea, from Dr. Dai Moon's group, from Seoul National. And as you can see here, that you can see all the areas with thrombosis. And I'm now collaborating with Dr. Dweck from Edinburgh, where we are going to be doing them in the treated or resolved COVID cases, so as to identify as to how many people continue to carry the thrombus even after the COVID has resolved. And now we have shown some of our pathologic studies that the thrombus after the COVID remains in the vasculature for a long period of time with the virus embedded in these thrombi. So we know that the venous thromboembolism is common in 30% of people. Strokes are common in young patients. Frequent post-mortem pulmonary emboli are seen. The arteries of the hands and legs, they have the involvement. Unlike the peripheral artery disease, the gangrene of the arms is very common in COVID. I mean, it's common, not very common, but it is common in COVID as much as the gangrene of the legs is. And the post-mortem multivascular microthrombi are often seen, which were not suspected before the death of the patient. So these are the data from our center. We have got a large registry of the COVID patients. We now have more than 6,000 patients in our registry. And as you would see here, that we did the observational analysis, was published in JAC. 2,700 subjects which were admitted to the Mount Sinai system. We found an association between in-hospital anticoagulation, both therapeutic and prophylactic, and improved survival. However, the latest trials have shown that the therapeutic anticoagulation may not be as beneficial, because there are significantly high likelihood of major bleeding episodes, and but the prophylactic anticoagulation is still continued as compared to no prophylaxis, or as compared to no anticoagulation. Our second report, which got published recently, when the 4,500 patients were seen, you can clearly see that the mortality was 50% lower in the people who were receiving anticoagulation as compared to those who were not receiving anticoagulation. Now, once the monocytes come into the circulation and they are loaded with these viral particles, you can clearly see that whether these are the epithelial cells or these are the monocytes, with or without the coronavirus in there, they basically start a significant upregulation of cytokines, even cytokine storm. What is the cytokine storm? When basically there is this abundance of the cytokines and they become perpetual, self-perpetuating, that you continue to increase the release of the cytokines from this to other organs, as well as within this organ, that it is causing its own release of cytokines. It is causing the release of cytokine from various other elements of the body, and you will see a large amount of IL-6, TNF, IL-8, IL-10, and IL-1, most importantly, the IL-1 here, and multiple of these cells and the cytokines play a role in perpetuation of this. So this is the monocyte, which is actually turning into a macrophage when they settle in the interstitium. All these macrophages can be brought as macrophages from the alveoli, which have entered from alveoli into the vasculature. And now the IL-1, as I said, is the most important molecule. It causes its own induction. More IL-1, more IL-1, more IL-1, more IL-1. And it leads to the endothelial cell activation, and also to the release of the nuclear factor kappa beta stimulation, which causes an intense cytokine storm in association with the monocytic or macrophage cells. And then there is also an upregulation, as I told you, of interleukin-6, which gets into the hepatocyte, works as the acute phase reactant, works on the liver, produces D-dimer. So now D-dimer, which is from the fibrinogen, which comes out of the liver, and as you can see that more fibrinogen, more pi1, which is the plasminogen activator inhibitor. So not only that you are getting more fibrinogen, which is the coagulation element, you are also producing the inhibitor of the fibrinolysis, suggesting thereby that more and more coagulation will start to occur because of the cytokine storm. So not only that we were having the increase in the activity because of the endothelial activation, now we are seeing that there is an increase in the activity because of the endothelial cell activation, but leading to the cytokine storm, and cytokine storm also resulting in the pro-coagulant and pro-thrombotic activity. Now you can clearly see that more and more cytokines are being released. So whenever there is a cytokine release, you will see that blue color here is for the survivors of COVID-19, and red color is those who died of the COVID-19. And you will see that whenever the patient has died, he had higher level of D-dimer, higher levels of the serum ferritin, higher levels of the interleukin-6, higher sensitivity of the cardiac troponins, as you can see here, and lactic dehydrogenase or LDH, as you can see here. So, and then you will see that more and more the lymphocytes are becoming lower here, and more of the fibrinogen that starts to get consumed in these cases. Now, as these macrophages reach the heart, they bring the coronavirus with them, they bring the coagulant activity with them, and there is a damage to the myocytes. Now, how the damage to the myocytes is occurring, I will discuss in a couple of minutes. But in our report of 3,000 subjects, we demonstrated that most of the people had mild release of the troponin, and about 33% of them. But only few of them had the intense release of troponin. Higher the troponin release, more sinister was the outcome, or more adverse was the outcome in these cases. And as you will see in these three panels here, the green are all the subjects who are admitted to the hospital. Blue are the subjects which were discharged from the hospital, and red are the subjects who died in the hospital. So you can clearly see that when the troponin levels were low, that is less than 0.03 nanogram per ml, you will see that of all the patients admitted to the hospital, most of them survived and were discharged. Only a few patients died. But when the troponin levels were highest, very few patients survived, and most of the people died in the hospital, suggesting thereby that the damage to the myocardium is one of the sinister findings. So the expectation was that when they found that coronary arteries were not involved in many cases, the question was that do they develop myocarditis? And people started to say that if the coronary arteries are normal in these cases, most of these people are developing myocarditis. So the autopsy series, which was presented by Dr. Cristina Basso from Padua in Italy, in combination with the Mayo Clinic of Rochester in Minnesota, as well as Mass General Hospital from Boston, they demonstrated that out of the 21 cases of autopsy that they had presented, most of the people demonstrated the presence of macrophages in the interstitium, as you can see here. And here there is a staining for macrophages. But there was no damage to myocytes, suggesting the presence of myocarditis. Lymphocytes were only present in very few people. As you can see here, up to about 14-15% of people, the lymphocytes were seen. And here, some of the myocyte damage, mild myocyte damage was found. However, as you can see here, that the fat of the epicardium or in the pericardium, there was a significant inflammation in those cases. And then in the microvasculature, they found significant amount of thrombosis or intravascular thrombosis in these cases, as is being shown in this particular case. But when you look at the myocyte, if we have got so much of macrophages there, which are bringing so many of the coronavirus, and the coronavirus is freely floating either with thrombus or without thrombus in the vasculature, it should get into the myocyte, and it should cause the damage to the myocyte. It should cause myocarditis. So here you will see that in this very elegant report from Dr. Eloisa Arbustini and Tavazzi from Padua, Italy, you can see that coronavirus is present in the heart, but it is present either in the fibrocytes or in the interstitium or in the macrophages. Here you can see that it's in the macrophage. It's a plumpy macrophage where it is present. And you can see here very easily, and it is coming out of the macrophage now. It is being exuded, or it's being thrown out of the macrophage. But even this macrophage does not get into the cardiomyocytes. It does not cause the cardiomyocyte damage. And that is great. If did not happen, all of us will have heart failure after the COVID-19, because it would have just totally damaged our heart cells, cardiomyocytes, quite like it damages our lung cells, and it renders the lungs completely fibrotic. It would have done the same thing to our hearts. All of us would have needed heart transplantation, quite like the people who have got the significant lung damage, they end up needing the lung transplantation. actually double lung transplantation. And why does that not happen? And here you would see this, that for the coronavirus to occur, to enter into the cell, you require both the spike protein as well as the co-stimulatory molecules, quite like the TMPRSS2. And these are the cells which are vulnerable cells, quite like lungs, quite like kidney cells, quite like intestinal cells. But what happens in the heart? Heart has the ACE2, very high expression of ACE2, very high expression of ACE2, even more than lungs. But it does not have TMPRSS. And because there is no co-stimulatory molecule, you are not able to structurally reconfigure the spike protein. And this spike protein is not able to bind to the ACE2, and it does not get into the cell. So it makes the heart cells almost invulnerable. It does not allow the cell to get into the cardiomyocyte. Now here you will see that heart, as compared to lung, has too much of the ACE2 expression. This is the ACE2 receptor, almost maximum, as almost close to what you see in the kidney, but even more than lung. But when you look at the RNA master blot here, you will see that in the lane 3, it is all heart, aorta, skeletal muscle. There is no co-stimulatory molecule. There is no TMPRSS. You can see in the colon, again it is there. You can see the prostate. You can see stomach. It is there. Similarly, you can see it in the pancreas, salivary gland, breast. It is there. Here you would see that the kidney, liver, small intestine, you can see lot of TMPRSS. Here you can see lung, trachea, lot of TMPRSS. So you have to have the virus, you have to have ACE2, you have to have TMPRSS for the virus to get into the cell. Since heart does not have it, it doesn't get into the heart. So why does the heart get affected at all? Why does it produce troponin? And now we feel that these are the cytokines. It is the interleukin 6, which is causing this heart to temporarily get affected. So most important thing which we recently presented was that the right ventricle gets involved. This is the autopsy study from Fox and Basso, and you can see that the right ventricle is significantly dilated. Right ventricle has become almost as big as the left ventricle here. Here you will see it is bigger than the left ventricle. Similarly, here it is equal to the left ventricle. So it becomes big. Right ventricle gets dilated. Right ventricle has significant damage. And how do I see the damage? How do I see the ischemic damage here? I see the damage by the complement presence in the myocytes here. As you can see, it has been stained. Now, why is it that the right ventricle gets affected the most? The reason is that right ventricular wall is a thinner wall, and that's why it is way more damaged when there is a cytokine excess or when there is a cytokine storm. And here you would see one of the person almost coming with the significant ST elevation with the ST myocardial infarction. However, patient had the normal coronary vessels. His right ventricle was normal, but within 3 days, you see his right ventricle has become significantly dilated here. And when the patient died, and there was a significant right ventricular dilatation, suggesting that the right ventricle is affected heavily. However, I would like to end our talk by two most important features which I want to bring in, and that is the delayed manifestation of COVID-19. What is the delayed manifestation of COVID-19? Now, as I told you that the thrombus may continue to be in the heart. The thrombus with the coronavirus, as well as there is a significant cytokine damage which might continue to occur. There could be a reactivation. There not be a reactivation. Still, it may be effective. And also that the edema that it has caused in the myocardium, quite like all viruses cause that. It may take a much longer time for the interstitium to clear the edema. And in this very elegant study, which was presented by Dr. Eike Nagel and Valentina Puntman from Frankfurt. In this study, they demonstrated 100 people, 78 days on an average after the COVID had resolved. They all have now negative swabs. They demonstrated that the magnetic resonance imaging abnormalities remain in 80% of cases. And now I have started doing the MR in all the patients who, during their acute COVID phase, had troponin leak. I basically definitely do MR even after their swab has become negative. After 3 months visit, I do their CMR. Their LV volume is increased, their mass is increased, their native T1 time is increased in 70%. The T2 time is raised by 60%, suggesting thereby that still there is an edema, and T1 is suggesting that there is an increase in the extracellular cellular volume in these cases. The late gadolinium enhancement was positive in 30% of cases. And then the pericardial, epicardial area late gadolinium enhancement was seen in 20%. You had seen in pathology that it was present in about 14-15%. No, it was present in close to 18%. And here it shows in the CMR that it is close to 20%, confirming the autopsy data here. So the T1, T2 increase was related to the troponin release in these cases. And they performed the endomyocardial biopsies, which only showed a little bit of an infiltration in the severe cases with the macrophages. But essentially, there was no myocarditis, although all the features of myocarditis by CMR present, but there was no myocarditis present in the pathology in these cases. So the second important thing, you might have heard about some people who have completely normalized, and then they come back with a second phase, which is not active, but they have got sudden heart failure that they present with. So when we see these cases are quite like Kawasaki type of a situation, but when you look at the endomyocardial biopsies, they are very different. The endomyocardial biopsy of the acute phase, the first phase, when there was an active infection, they demonstrated some infiltration in these cases. While when they come as a delayed manifestation, there is no active disease, but there is possibility of a cytokine or the damage occurring because of the intravascular thrombi. You see endotheliitis in these cases or vasculitis in these cases, and you basically see a very different picture, and these people respond very well to the steroids. So you give them the dexamethasone or prednisone in these cases, and also the infusion of the interleukin 6 antagonist, which is given in these cases, like tocilizumab. These people do very well, and we are able to discharge them from the hospital. So to finalize, in these cases, when you see the delayed manifestation of the myocardium, it occurs either because of the significant cytokine excess, quite like what we see in the CAR T cell therapy, that there is a hyperimmune response in the body, which is because of interleukin 6, interleukin 2, and TNF alpha, or it is because of something similar to what we see in the checkpoint inhibitor therapy, that there is a macrophage activation, and these macrophage activation produce lots of cytokines and they cause the damage. And COVID-19 does something similar, either quite like the CAR T cell therapy or quite like the immune checkpoint inhibitors in these cases, and they result in a similar kind of cardiotoxicity. So, ladies and gentlemen, it is an intriguing disease. It is present in the body once it has ruptured through the defense of the lung, but it is not able to infect the myocytes, but is able to produce significant damage, but it is not able to produce myocarditis in such cases. So what we need to do is we need to recognize it right. The people who have resolved or who have recovered, we need to follow them properly. If they had the high troponins, we will like to get their CMRs done, and we will like to follow these cases more closely. these patients need a close follow-up, whether their lung functions, whether it is their cardiac function, or whether even it is their neuronal or the brain affliction. We really need to take care of these patients. This has taught us a lot. We will continue to learn on a daily basis with this disease, and we need to be careful so as to prevent the future abnormalities in such cases. Thank you very much.
Dear Jagat ji, what an incredible lecture. Before I open to Professor Tinoco start his comments, I would like to highlight that when we are facing a new disease, unknown disease, we need to fight taking all the weapons. The first of them is definitely pathophysiology, number one. I would say that number two, we would need registries, because we don't have time for international randomized multi-center clinical trials. We need registries. And we need international collaborative efforts to increase the caseload, to reduce the noise, and to bring signals. You clearly gave us a wonderful view of a brilliant cardiologist, because you showed a lot of pathophysiology to direct our targets. And you share with us some beautiful slides, one of them from Zina.
Yes.
I was excited about that. And number two, you brought, as I learned from you, your incredible multinational network. And then you made us revive Eloisa Cavazzi from Italy. Then you collect all the information from your international network to bring us some information. And now we are getting some targets. We are getting some therapeutic results to help people. And before I open to the public, I'd like to invite Dr. Tinoco, who is a great researcher, and to share with you and Professor Tinoco that there are many clinical investigators connected to our network. Right now, Professor Dalton Precoma from Paraná is connected to us. There is a clinical research network, more than 50 cardiovascular investigators connected to your lecture. Then with this in mind, I'd like to invite Dr. Tinoco to bring his comments, and then I will start to send you the questions from the audience. And I have my personal private case, and I want to share with you one case I just saw today. Dr. Tinoco, thank you for joining us.
This is a fantastic lecture, Dr. Narula. Congratulations. It's very important during this pandemic time to return the past, the autopsy and clinical anatomopathological correlation. This is a very important for cardiologists, the old cardiologists, Italian and Germany, create a robust clinical pathological correlation in our history cardiology. And now the connection, the physiopathology using and connection, the cardiac resonance create a new environment to detect and create a new vision about this physiopathologic and etiologic aspect in COVID myocardial disease. Dr. Narula is very interesting because the group, the University, São Paulo University, published in the British Medical Journal in Lancet the first case, a young boy with a necropsy using electronic microscopy identify the coronavirus inside the cardiomyopathy. This is one case, but this is very important because this is during many months I studied day by day, and no case about the cardiomyopathy with a presence of the coronavirus. But this physiopathology, the macrophage, and the connection cytokines, and create a new kind of the definition, the myocarditis, because in the previous definition, myocarditis don't use the macrophage with a criteria. It's very important to demonstrate the necrosis and cardiomyopathy necrosis and presents the lymphocytic infiltrates. This is, in my opinion, is a new vision about this kind of the cardiotoxicity, and now incorporate this new vision in my observation, the cases, the myocarditis. Dr. Narula, in your opinion, the use of the methylprednisolone in this case with a huge damage and heart failure with a high level of the cytokines is a good strategy in this case.
Professor Tinoco, very well summarized, and I think you summarized it even better than I spoke when you said that it is a novel kind of a mechanism, because earlier I fully agree with you that the way the myocarditis used to be defined was the presence of lymphomononuclear cells with a myocyte damage sitting next to it, and now it is more the macrophages causing it, as well as the cytokines causing it, and the actual myocyte presence of virus, which is necessary for the definition of the viral myocarditis. When we talk of the Coxsackie and other kind of viruses, that these viruses sit in the myocyte, that is not seen, and it is only a case report, quite like one, I fully remember the one which came in Lancet from Sao Paulo, and there was another case which was the Kawasaki type of a picture in the child, where also it has been demonstrated. So there are about 2 or 3 reports, and the exceptions actually prove the rule here, that it is kind of what we should say as a cardiac cytokinopathy or something like that, which we are seeing. And since it is a cytokine axis, there are 3 cases which we just submitted for the publication to Jack case reports. And so one which came on first day, we were not able to recognize it. And this is in collaboration with my friend from Las Vegas, who's chief of cardiology there. And so this first case comes in, and within about 16 hours, the patient died, because we were not able to identify the right kind of a thing by the time the COVID diagnosis was made and all those things. And we recognized the situation, the patient was gone. learned from that case, and the next two cases were where we were able to use the tocilizumab, and we were able to use the steroids, and we were able to protect them. And within 3 days, these patients resolved and recovered. They all were swab negative. They all had a previous positive swab. So basically, it resolves. And the similar things we have seen in the ICI inhibitor cardio-oncology cases, where you give the checkpoint immune inhibitors, and they have the macrophage damage. You give them and you see similar picture in the CMR, and you give them the steroids, and it melts. It recovers immediately. So basically, something very similar that we are seeing in these cases. And you were very right that this is a newer entity. And as Dr. Botello just said, that this is a new condition where we need to learn on a day-to-day basis. And this was when the patients were coming in March and April, that on a daily basis, we were learning today and applying tomorrow.
Okay.
We learned all about the echocardiograms today and applied it tomorrow. So you both have presented it very well, and I'm grateful for adding to what I presented.
Please, more two questions. What is your opinion about the colchicine in this presence of the perimyocarditis? This is your practice, use colchicine for patients with myopericarditis in the COVID setting?
So, great question, Dr. Tinoco, and as Dr. Botello is saying, that you are one of the best philosophers and thinkers of the country. The important thing is that colchicine, you do agree that not only colchicine, even the canakinumab, something similar, which is working on the IL-1, it helps in the myopericarditis cases, as was the recent paper that you saw in JAC. But more importantly, yesterday, which you are obviously aware, yesterday the paper came again from Montreal and Quebec, that you have seen the study which is called qual corona, or the colchicine in corona, and has been showing the impact. So the study came yesterday only, and I have not been able to fully review it, but yes, they are showing a significant, in a randomized, properly done study, they are showing the effect of colchicine. And when I looked at it, I started admiring some of the old drugs, that this is the time we really need to start repurposing some of the very well proven drugs in past.
The last question about the new vision about the Takotsubo disease. During the December 2019, a very interesting paper, the English cardiologist, that analyzed the macrophage in the peripheral and used a marker, a new marker for a material to use in resonance with a metal material, and demonstrate the macrophage present inside the heart, create inflammation in the typical cases of the Takotsubo, create a new vision about the pathophysiology. What's your opinion about this new kind of vision, the Takotsubo, mental stress, macrophage activation, and myocardial inflammation?
But again, Dr. Toko, a superb question again. And I fully agree with you again that it was a novel methodology, novel pathophysiology which was presented, and it could function something like again a very high macrophage activation and a hyperimmune state, which may be occurring in such a case. However, what it did was that it reminded me of one of the cases which I had seen when I was doing my fellowship back in early 1990s in Mass General Hospital. And I distinctly remember one of the patients. And I remember her name also, obviously, for confidentiality. I obviously cannot speak much, but there was a patient whose son had committed suicide. And she was a person who was suffering from pheochromocytoma, and son committed suicide. And actually, pheochromocytoma was not known. And when she came with the pulmonary edema and found to have the normal coronary arteries, and the endomyocardial biopsy was done, which demonstrated significant damage to the subendocardium and global subendocardium. And why? Because normally when you have the damage to the subendocardium in the ischemic condition, 3-4 layers of the myocytes are spared because you get the oxygen from the blood. But whenever you have pheochromocytoma or things like that, the damage occurs more in the first 3-4 layers. And then there were lots of macrophages sitting in there. And that now, at that time, we did not even understand that it was a Takotsubo. Now, in retrospect, I think it was a Takotsubo syndrome. And I've seen significantly large number of macrophages in that particular case. Now, is that macrophage present because of the myocyte damage that is occurring, and they have come there as the scavengers, or they are the ones who are actually a part of the syndrome? Is it a macrophage activation syndrome, MAS, or is it the macrophages, or it is both, a combination of both? So I do not know. And although I fully agree with your suggestion that this is a very novel thing, I think we really need to know a bit more before we will be able to see the cause and consequence distinction between the two things. But in the Takotsubo's, there is always a significant increase in the circulating the stress markers. Are they responsible for myocyte damage? Are they causing, or are they inviting the macrophages for repair and removal? I do not know. But yes, if macrophage is the leading cause and it is the cause of the whole thing, we probably are looking at something very novel. And macrophage activation syndrome probably has different, then would have a different manifestation, Takotsubo being one out of them.
Thank you, Dr. Narula. Botelho, please.
Thank you.
Thank you, Dr. Tinoco. Dr. Narula, we have some questions, and we still have time. We want to take all possible information from you. One of them, we started a national program with the Brazilian Society of Cardiology to offer telemedicine to help government, to help Secretary of Health, many states. We wanted to help them to support cardiovascular disease because of the late events you mentioned, and also the comorbidities, because patients are not visiting their doctors, and so they're coming with complicated diseases. We observed an increase of acute myocardial infarction mortality, and our emergency department started to rescue cardiac arrest at home. Then we offered, the question is, together with the Brazilian Society of Cardiology, we offer Conexa telemedicine network in order to physicians helping patients and GPs to support cardiovascular disease. What is the impact of this delayed presentation? I think is the third wave of cardiovascular complications. Have you used such tools, telemedicine, to help patient without bringing them to the hospital? This is one question. Then I want to share with you one real case. But let's first comment on telemedicine. How is Mount Sinai dealing with telemedicine to support these late events?
Excellent question again, Dr. Botelho. First important thing that you folks are the telemedicine kings. I don't think that we can match with your outreach and the way you have disseminated. And I admire the way you did Latin study and brought the STEMI. I think that is a model for the entire world. And when we published it in the circulation last year together, I admire your conceptual advances in there. So again, when it comes to the telemedicine network, yes, we are doing the telemedicine network, but at least I can tell you that we have not become as established as you people are. So I have to learn from you rather than you asking me. That is number one. Number two, that from the myocardial infarction that you are saying, yes, there is a likelihood that there may be a delayed thing which may be happening in this, and the possibility is that inflammation in the plaque is causing the atherosclerosis to progress at an accelerated rate. And as a matter of fact, with Dr. Leslie Shaw and with Ron Blankstein, Leslie from Cornell and Dr. Blankstein from Brigham and Women, we just put a grant together to the NIH where we are looking at the CT, those people who have had CT in past, and then they developed the COVID, seeing 6 months to 1 year after that, whether they accelerated their disease as compared to those people who have not had the COVID infection and they have their second CT scan as a control. And I would be very privileged if we can invite you to participate in something like that. And it is an NIH study. And so we basically, it would be a great service to the people if we are able to demonstrate to them that it is indeed causing an acceleration. And if it is so, bringing to Dr. Tinoco's point again, that would colchicine be a way to go in such cases? Should we really start the patients who have the coronary artery disease in past and those who have developed COVID, they must be put on colchicine or something like that? Colchicine in any ways recently has been shown to be important in the patients with chronic stable coronary artery disease. Earlier it was shown in the acute coronary syndrome. But if we start doing it, it might be one important way to go in such cases and being treated with the colchicine in these cases. So I would invite you to be there because again, on one hand, you people from DASA are the kings of CT imaging. On the other hand, from Conexa, you are the kings of telemedicine and be putting it together. And then you have got the great outreach in terms of the CROs. So I think you are probably the best suited for resolving a problem like that. And it will be truly a privilege to work together on that proposal.
This is just incredible. This is an absolute proof of synchronicity. Because before sharing the question, I told you that I'd like to share one real case that I just saw. I saw the patient today. The patient is a 34-year-old boy, an athlete who happened to have COVID like 20 years ago. We don't precisely know. It was like 20 days ago, sorry. We don't exactly know, but it's around 20 days. He's already IgM positive, but PCR negative. And he came for a regular lung CT, asymptomatic. The guy from the coronary CT, who was trained with Ricardo Curi, that you know very well. The guy recognized calcium in the LAD. So he recommended to see the coronary arteries. It was not scheduled to see the coronary arteries of a 34-year-old asymptomatic guy. And then it came the question, a vulnerable plaque in the proximal LAD. Lipid-rich, ulcerated, with a very, very small remodeling. What is this animal? He's an athlete. He's not on hypertension, no high cholesterol, no risk factor, zero. And now it comes with a vulnerable plaque in the proximal LAD. What is this animal? May it be the endothelium lesion that you mentioned in the beginning of your lecture? Number one, what to do with this guy? Should we give him DEPT, clopidogrel and aspirin, statin, or PCSK9? What to do with this guy? There is no data on population study to decide there is an asymptomatic patient with a vulnerable plaque after COVID. This is a case that I'd like to share with you the image. I will ask the guys to send you the image so that we can learn. And the patient is absolutely asymptomatic.
I mean, I fully agree with you here, and that is what our hunch was, and that is what I wanted to look at, and that is why we wrote the grant, and I will share the grant with you. And as soon as it is funded, because NIH is very much interested in it, so it is being reviewed at this point in time, and we should be hearing about it. I think we will come to you and start working with you on that.
Great, great. Any comment, Tinoco? Have you seen something like that?
Nowadays, Roberto, Professor Narula, the Brazilian Cardiology Society create a task force to help Manaus because the health system collapsed, and using the telecardiology. Dr. Marcelo Queiroga, our president, coordinate this task force to introduce a heart line to help cases the acute coronary disease, and put cardiology with the primary care physician and population to permit allow create a health literacy about the heart disease, because a huge number the patient in Brazil develop sudden death during this pandemic time.
Thank you, Tinoco. And we have some questions from the audience. I will answer them over the chat, because we are now close to 9 p.m., 7 p.m. New York. So I think it's time to thank everybody. Thank Professor Narula for your time, and Professor Tinoco. I believe the people from organization will send some question to the audience. Is that correct? If you are listening to us, am I allowed to close this meeting? And thank very much, Dr. Narula. You reached a fantastic audience, high quality group of cardiologists. We're connected, listening to your brilliant lecture. It will be available in our website, and Conexa, the Brazilian Society of Cardiology, and also the Ânima and Inspirali educational group would like to thank you very much. One last comment is that I will comment in Portuguese, because some people in the chat question. Nós optamos por não fazer a tradução simultânea, porque ela dificultaria a sincronização da fala, do slide, e a experiência mostra que o aprendizado é pior. Então, fazer a tradução poderia piorar o entendimento de uma fala tão precisa. I comment with them, Jagat, what we have discussed about simultaneous translation. We decided not to translate because it would compromise the synchronicity of your brilliant and precise talk. So people are just questioning when will be the next meeting. We'll soon let you know, everybody, when we'll have our next meeting. And again, Jagat, thank you so much for your time. And we look forward to keep collaborating with you and the NIH. Please send us the protocols. We are looking forward to work together. The Brazilian Society of Cardiology, Conexa, and Inspirali and Ânima Group. Thank you so much. See you next meeting. Bye-bye.
Bye-bye.
Eu continuo aqui no ar para ver se o pessoal